Medicine at the David Geffen School of Medicine at UCLA, where he also serves as Vice Chairman of the Department of Internal Medicine, Chief Division of Endocrinology, Metabolism, and Molecular Medicine. In addition to writing over 100 papers in peer-reviewed journals, Dr. Friedman has written chapters on thyroid and adrenal for the well-known textbooks. Dr. Friedman has extensive experience with complex patients from all over the country with thyroid, adrenal, and pituitary disorders. Let's please welcome Dr. Friedman.
Nice to see everybody. I've many patients I've seen before and some new ones, and good friends here. And imagine some great work, and I'm really excited to be here this morning. We're going to talk first about nuances of hypothyroidism. The outline of my first talk today, we'll start off talking about the hypothalamic pituitary thyroid axis. Do we have a pointer? Doesn't matter if I have central or primary hypothyroidism, how to diagnose central hypothyroidism, how important is the TPO antibody in the diagnosis of primary hypothyroidism, what does it mean to have Hashimoto's, which thyroid medicine is the best, what is the difference between desiccated thyroid and synthetic thyroid hormones, what about taking only T3, is reverse T3 important, and is diet important in patients with hypothyroidism? So we've got a pretty full agenda for the hour or so. The different axes of the pituitary, including the order of the first affected to the last affected. Growth hormone axis is the first affected. We'll talk about that in my lecture on macrolin. The gonadal axis that regulates testosterone and estrogen is next. The thyroid axis, which we're talking about today, is made by the pituitary cells called the thyrotropes. This axis has TRH from the hypothalamus, TSH from the pituitary. The thyroid makes T4 and T3. The adrenal axis is the most preserved. Also, the corticotropes made by the pituitary, the CRH, ACTH, and cortisol axis. You have to have extensive pituitary damage usually to have this affected. And the last axis is the posterior pituitary hormones, antidiuretic hormone, and oxytocin.
Excuse me, Doctor.
Yes.
Is your PowerPoint going to be available?
Yes, it is. Yeah.
Thank you so much.
So both the talks and the slides will be available. It'll be on my website in about 3 days or so.
Thank you.
Okay. The thyroid is in the neck. It's a little bit above the trachea. There's 2 lobes. It looks sort of like a butterfly, as you can see right there. The hypothalamic pituitary thyroid axis starts with the hypothalamus in the brain just above the pituitary, releases the hormone TRH, goes to the pituitary to make TSH, it goes to the thyroid gland to make T4 and T3. The T3 primarily binds the thyroid hormone receptor in heart, liver, bone, and CNS brain tissues. The conversion, we'll talk a lot about conversion of T4 to T3 occurs mostly in the liver and muscle and some other cells. And the T4 and the T3 feedback and inhibit both TRH at the level of the hypothalamus and TSH at the level of the pituitary. So since this is a pituitary conference, we want to focus on central hypothyroidism, the deficiency of thyroid from a pituitary problem. And this is common. Many patients with pituitary disease have central hypothyroidism. It's common even with small tumors. Mild cases may be manifest clinically more than subclinical hypothyroidism when you have a primary thyroid problem. This is due to the actual thyroid hormones are low in central hypothyroidism. The T4 is often low, while in thyroid disease itself, primary thyroid disease, the TSH is high. Often the T4 and T3 are normal. The signs and symptoms of central hypothyroidism are similar to that of primary. In general, the lab test you look at is you look at a low free T4 in the face of a lowish TSH. And in most cases, which is the mild cases, which is what I usually experience, the free T4 is between 0.07 and 1.0. It a little depends on the units of the lab, but in general, this is sort of the range. Measuring a free or total T3 is often not that helpful. So there are ways to confirm it, although both ways are really not too practical. One is a test called a TRH test. TRH has not been available for about 20 years, at least in the United States. When you give TRH in the old days when it was available, you would get a blunted TSH response to TRH, but this test isn't available. When I was at the NIH, we pioneered a nocturnal TSH test. The TSH should rise at least 1.5-fold between 5 p.m. midnight in normal people, but in patients with pituitary disease, it's not, they don't rise, so you don't get this 1.5-fold increase. It's hard to get blood at midnight. People don't do this anymore, but in theory, this can be done. So we usually base this diagnosis on a clinical scenario. Somebody that has symptoms of hypothyroidism, has pituitary disease with other hormones deficient, and has a low baseline free T4 and a relatively low TSH. So what's the difference between central hypothyroidism and primary hypothyroidism? Central hypothyroidism, you have a low free T4 and a low or normal TSH. You have imaging of the pituitary that shows either a micro or macroadenoma, prior surgery, prior radiation in central hypothyroidism. You have other defects, especially growth hormone defects. Growth hormone, as I said, is the first hormone affected, so you usually have other pituitary defects if you have central hypothyroidism. Primary hypothyroidism, on the other hand, is a disease of the thyroid. You have a high TSH that compensates and goes up to compensate for the thyroid not working. Usually the free T4 is usually relatively normal. Sometimes it's low. You usually have, and we'll talk about this a little bit more, a positive thyroid peroxidase or TPO antibody. And you usually have a goiter and a large thyroid or ultrasound evidence of Hashimoto's. The gland looks hypervascular, nodular, lumpy on ultrasound, so the ultrasound is sometimes helpful for primary. Are the treatments different? Yes, they are. So in central hypothyroidism, we aim for a free T4 in the upper range of normal, about 1.5 to 1.7. The TSH should be suppressed. It often doesn't help really to measure it because you're looking at a low TSH. It's pretty much always low anyways. In contrast, primary hypothyroidism, you aim for a normal TSH. If the patient's on T4, it's usually the TSH is usually normal. If they're on desiccated thyroid and T4, T3 combinations, sometimes it's lower. But you usually have somewhat a normal TSH in that. And you aim for a normal free T3. It doesn't have to be in the top half of the range if you have primary. Now, a lot of my patients have both, though. So what do you do if patients have both central and primary hypothyroidism? I treat it like central hypothyroidism. I still aim for that highest free T4 and a suppressed TSH. And what's the role of growth hormone deficiency in the story here? So growth hormone helps with T4 to T3 conversion. So untreated patients with growth hormone deficiency may have a low free T3. That, to me, is a sign that somebody may have growth hormone deficiency and should be warranted for testing. And then those patients, especially the patient with growth hormone deficiency, if they're not treated for their growth hormone, they probably benefit more from a T4, T3 combination or desiccated thyroid that has both of them, that has both T4 and T3, because they really have a problem with low T3. At least in the literature, and occasionally patients that are on T4, T3 treatment who then start growth hormone, they're converting their T4 to T3 more, so they may need less T3. I haven't found this happens, but there's an article in the literature about this, and I talked to the professor who wrote that article about this. It's really the T3 that's the important one, and usually in central hypothyroidism with growth hormone deficiency, you have a low T3. You either need to get on T3 or get on growth hormone. So Hashimoto's hypothyroidism. Hashimoto's is very important to distinguish, to determine if you're considered a primary. Again, it's not so important for central because in central it's a disease of the pituitary, not a disease of the thyroid. TPO antibody stands for thyroid peroxidase antibody. This is a marker for Hashimoto's hypothyroidism. Some people measure the thyroid globulin antibody. That doesn't have anything to do with Hashimoto's. In general, I don't recommend that unless people have thyroid cancer. By far, the most common reason for primary hypothyroidism is Hashimoto's. So if somebody comes to me with not a pituitary problem, a thyroid problem, I really try to look carefully for the Hashimoto's with the TPO antibody. So if somebody does not have a TPO antibody, they don't have something on their pituitary, they don't have something on their thyroid, like prior surgery or radiation, I think it's unlikely they truly have primary hypothyroidism. Some people do, but it's not that common. So I use the TPO antibody to determine who with a high normal TSH or a slightly elevated TSH should go on thyroid medicine in primary hypothyroidism. If the TPO antibody is positive, most of the time I'll put the patient on thyroid medicine. Sometimes if a patient has a lot of symptoms of hypothyroidism, a goiter and positive TPO antibodies, even the TSH is normal, I would start them on thyroid medicine, and this may be helpful. On the other hand, if a TPO antibody is negative, you have a healthy gland. It's not being attacked. It's not attacked by antibodies. And I usually don't put somebody on thyroid medicine because that gland can recover. It's a healthy gland unless the TSH is quite high or they have central hypothyroidism. That's why it's important to distinguish between the two. What about if you have central hypothyroidism, if you have a pituitary problem, you should get the TPO antibody anyways? And I say yes. First of all, Hashimoto's, but not pituitary problems usually. Hashimoto's runs in families, especially among females. It can be passed down to female family members, so I would recommend people getting it to know if they're at a risk of passing this down to their children. And also, there's syndromes of these autoimmune diseases that run together. Somebody that has Hashimoto's, they can also have Adthyza disease, pernicious anemia, which is low B12, and celiac disease. So for all these reasons, I think it's somebody's helpful to get a TPO antibody, even if you have a pituitary disease. Most of my talk today is going to be on treatment. There is many options for thyroid hormone treatment. You can give T4 or levothyroxine. Levothyroxine is a generic name. Synthroid, one of the brands. Levothyroxine, another brand. Tyrosine, another brand. Unithroid is the brand. I'll talk a little more about Tyrosine later in the talk. Unithroid is actually can be given as generic. Forgot the company's name. Lanic. So Lanic makes a generic levothyroxine. It's the same as Unithroid. So if your insurance requires you to get generic, you can have a doctor write for Lanic brand levothyroxine and you'll get the Unithroid. We'll talk about why I don't recommend T3 alone, cytomel or liothyronine. We'll talk a lot about T4, T3 combinations. And then we'll talk about desiccated thyroid. Some of the common brands of desiccated thyroid are Armour, Nature Thyroid, WP Thyroid, Urfa is from Canada. These are all from pig thyroids. Thyroid Gold is something you can get on a website. Doesn't need a prescription. Not sure how good it is. It's from cows from New Zealand. You can be on desiccated thyroid T4 combinations. You can be on desiccated thyroid T3 combinations. And I would say, just like blood pressure, there's lots of different medicines for blood pressure. Different people react differently. You want to look at the scenario. I would say there's lots of different combinations for thyroid medicine. And what my job is really to try to figure out who's the best candidate for each medicine based on symptoms, labs, and prior experience. It's interesting that, although most doctors treat hypothyroidism with levothyroxine or T4, lots of studies have shown these people don't do well, have a poor quality of life, somewhere I think 15 to 20% in literature don't do that well in T4. I'll get a little bit of the reason why about that in my talk. But it really shows that people on thyroid replacement aren't doing that well. They need to get their treatment individualized, and this one use of T4 alone doesn't really work that well. There have been some studies, but not all studies, that show a benefit of T4, T3 treatment together over T4 alone. And I think more and more endocrinologists are using the T4, T3 combinations than they were 15 or 20 years ago. And there was a study showed that, especially endocrinologists in the United States, use them more than sort of other places around the world. But I think things are changing. A lot of doctors see.
Is that based on symptom or lab results?
Is what?
Where they treat with both?
Well, this was like a survey of doctors. They didn't say why they treat with both.
Okay.
It just says, do you use T4? And I think I filled out the survey. Do you use T4? Do you use T4 plus T3? Do you use Armour or desiccated thyroid? And in the United States, it was still majority use T4 alone, but it was like maybe 30 or 40% use T4, T3. And in Europe, only 5% or 10% use it. So I think in the United States, more and more, especially endocrinologists, I think primary doctors don't really do that much, but more and more endocrinologists are using this combinations. There was a very interesting and large study in Italy that took patients without a thyroid. They had like a removed for thyroid cancer, for example, and they gave them T4 replacement to give them the proper levels. Their TSH was normal. 15% of them had a low serum free T3. So it really shows that some people, even just by looking sort of crude, looking at the free T3 on T4, that's not enough. It doesn't tell you what happens inside the cell. My guess is it's more are not getting inside the cell. But it shows that this study shows that a lot of patients have low T3. These patients may have a different set point for TSH secretion, and many patients need a T4, T3 combination to achieve both normal free T4 and free T3, which I think everyone would say you should certainly do that. And I think it supports measuring the free T3 and free T4, which many people don't even do. Some people just look at GSH once they're on treatment, but I think it shows that it's important to measure both free T4 and free T3. And then you can give the T4 and T3 either combination therapy or with desiccated thyroid. Now, another study that came out, sort of about 10 years ago, looked at the gene that does the type 2 deiodinase that converts T4 to T3. This gene had what's called a polymorphism. This means a change in the DNA that caused it to not work as well. They didn't miss the enzyme, it just wasn't working that well. And it happened to about 16% of the patients. So 1 out of 6 patients or so have this polymorphism that they don't have, this gene doesn't work as well as it should. These patients required a higher T4 dose, and they had more psychological problems than those that did not have this deiodinase polymorphism. The study didn't really examine whether they would benefit from T4 to T3 combination. They actually didn't even measure the enzyme. They just looked at the gene coding for it, but I think this is very provocative that a good number of patients don't convert T4 to T3 properly. So these, I think these two papers, they sort of came out about the same time, about 10 years ago, really sort of questioned the idea about that should patients with, all patients with hypothyroidism be treated with T4. And at my county job, patients have lots of other problems. Almost all of them I give T4, they all do pretty well. But I think there's a percentage of people that sort of vocal people that would come to see me, they're not satisfied with their current care, they would benefit from different combinations. So you can use T4 and T3 combinations, or you can use desiccated thyroid that has T4 and T3 in it. I'll discuss this a little later. T4 alone, I'll show you some of my data. T4 alone could lead to this high reverse T3, which blocks T3 from binding to receptors. That's another reason why potentially people don't do that well on T4, besides just that they have so low T3 levels. And my guess is somewhere about 15 to 20% of the population needs this T4 to T3 combination to really do well. They're the vocal minority. They're not doing well. The sign of the majority goes to their primary doctor. They're on T4 alone. They're doing fine. But a very significant number of people are not doing well, and it really deserves sort of this individualized treatment that they would probably get from a thyroid specialist like myself. So interesting, there's different types of desiccated thyroid. The first one is called Armour Thyroid. Armour, as people know, is a company that makes hams. So they had these leftover thyroid glands they didn't want to sell to the consumer because it has thyroid hormone in it. So they had to figure out what to do with these thyroid glands, so they decided to make a desiccated thyroid preparation. It's been around since the 20s, so we're looking at almost 100 years from now, 100 years of use. And they were very popular from the 20s till about the 60s, when, I guess it's been almost maybe 50 years ago, so sort of in the 60s, sort of around John F. Kennedy had hypothyroidism, Mass disease. He got synthetic T3. Not sure why he didn't get Armour, but sort of around the 60s, doctors started prescribing synthetic ones, Levothyroxine. They were heavily marketed by drug companies. Several editorials came out against desiccated thyroid. Everybody said it wasn't standardized, it wasn't pure enough, which I don't think turned out wasn't really the case. And so the movement shifted to giving synthetics, and now there's an interest in coming back to using desiccated thyroid, either because the patients aren't doing well on the T4 is probably the main reason. There's an interest in using something the patients consider more natural, less synthetic. I mean, the Armour still comes from a big vat. It's still from a company. It's still packaged in a pill. It looks the same. It looks like a pill. Doesn't look like a pig thyroid, but I think some people at least consider it, more natural and less synthetic. Most endocrinologists' consensus guidelines, including by the American Thyroid Association, recommend the use of synthetic levothyroxine to avoid desiccated thyroid, and it's partly due to this erroneous belief that desiccated thyroid is not standardized, which again is not true. Desiccated thyroid has a higher T3 than T4 ratio than human thyroid. So if you're on desiccated thyroid alone, you may have a high free T3, a low free T4, and a lowish TSH, which led me originally to add a little bit T4 back. And I'll talk about sort of why I changed my thoughts about that when we look at the reverse T3. But that's a general pattern that people see. Armour Thyroid is made by Forest Labs. And concern about variations in preparation, the lack of standard are not true. it's really been shown that the products are quite standardized. There's a brand of thyroid called WP Thyroid. It has the least amount of binders or fillers in it. There's another brand called Thyroid that has a little more binders and fillers than WP Thyroid, still pretty good. Both of these are made by RLC Labs, and both of them have been on back order for about a year and a half. The company doesn't give us a straight answer why. Seems to have something to do with maybe getting the ingredients for it. It's coming back now some, and I've been able to purchase some WP Thyroid that I could sell to my patients in my office, and possibly we're working on trying to ship it around the country. And I think I would say the WP Thyroid is probably the best preparation on average, although each person does differently on different ones. There's another one called Endocrinologist. It's made by a company called Celiac. It's an excellent product, pretty readily available. Interesting enough, CVS does not carry it. And they send me every day, I get these faxes from them on back order, which is not true. They made a business decision not to carry it. It says it on the NP website, and I think it's quite annoying, so I can send it back. I send it back to the website, say, please fill this, you know, you have to follow what the doctor writes. And sometimes I guess they fill, and sometimes they don't respond to me and have to send the patient a different. Walgreens, right, so it's only CVS. Right, essentially, I think all the CVSs don't carry it, and everything else, Walgreens and Walmart and all the others do have it. Very interesting. So one thing that I think people don't really understand that I think is crucial is T3 in the desiccated thyroid and T4, T3 combinations has a short half-life. That means it's gone after a couple hours. So it really needs to be given twice a day. If somebody takes desiccated thyroid or T3 once a day in the morning, they'll be hyper after they take it, most likely, not everybody, but most people. They'll be hyper after they take it. And then a couple hours later in the afternoon and the evening, it's really low. By the next morning, it's really gone from the system. So I think people do worse if they're on once a day desiccated thyroid. They sort of don't get the advantage of that T3 because it's gone most of the day. So it really has to be given twice a day. Maybe some people do 3 times a day, but most people do pretty well on twice a day. The second dose has to be given about 2 to 3 p.m. or so. It can vary. I talked to a patient who seemed like she started getting tired around noon. I moved it up a little bit. Some patients feel like they're having a lag at nighttime, so we push it back a little bit. But I usually give it in the afternoon. I'm a little worried about giving it right before they'll go to bed because I think it keeps people awake at night, although it doesn't affect everybody that way. So I usually aim for this in the last afternoon, about 2 to 3 p.m. There may be other components of the thyroid missing in synthetic ones that are present in these. So there's some theoretical advantage of desiccated thyroid over synthetics. I usually give it to people who are really just not doing well in T4. Sometimes I start T4 up on people, but most of the time people come to me already on T4 not doing well, and I switch them to desiccated thyroid. And I would say the majority of them do better. Small percentage of them do worse, but most of them do better. Some about the same. Most do better though. And then for the hypopit patients that have essential hypothyroidism, I usually aim for a free T4 and free T3 in the upper normal range with a suppressed TSH. Primary, I sort of do the same thing also a little bit, but certainly for this people with essential hypothyroidism, that's what I would do. So it's interesting that an article in the main journal of Endocrinologist, Journal of Clinical Endocrinology and Metabolism, came out in May 2013 by He Wang and colleagues from the Walter Reed National Military Medical Center of Adthyza. They did a randomized crossover study. That means each person got either levothyroxine or desiccated thyroid, and then they switched them in the middle, and they got the other one. They used 70 patients. In the introduction of this paper, they commented on how the dose of armored thyroid and desiccated thyroid has now been standardized, and they cited a paper in this, it's not a real journal, it's this guy, J.C. Lowe, passed away, who had his own journal called Thyroid Science that says, indeed, that armored thyroid has been standardized so that 1 grain of armored thyroid contains 38 milligrams of levothyroxine and 9 milligrams of liothyronine, and they based this and sort of on their dosing they gave comparing the T4 and the desiccated thyroid. So all these patients in the study were on levothyroxine, and they had a normal TSH before the study started. 78 patients were randomized, 70 concluded the study, with 35 receiving armored thyroid at the beginning and 35 receiving levothyroxine at the beginning. The dose of the levothyroxine or the armor was adjusted after 6 weeks, and the TSH was between 0.5 and 3. Maybe it might be better to get the TSH a little lower, but I think that was a reasonable choice. They were on that dose for an additional 10 weeks. So after 16 weeks, 6 weeks on the adjustment period, 10 weeks on the more stable period, they were switched over to the other compound, same adjustment at 6 weeks, and continued for another 10 weeks. And in general, the results were there was not a statistical improvement in symptoms in general on health questionnaires and neuropsychiatric testing, which means that the desiccated thyroid didn't do better or worse than the levothyroxine. There was a trend, it was going in that direction, they would have had more patients, they would have made significant. The people that did better on these tests actually in the desiccated thyroid group compared to the levothyroxine group. The group that was on the desiccated thyroid lost 2.86 pounds more than the people on levothyroxine, so they had a significant amount of weight loss. Their HDL was slightly lower, so that could be worse. It wasn't also significant, but HDLs with the good cholesterol was a little bit lower. The total T4 and the free T4 were lower on the Armour thyroid than on levothyroxine patients, so that's why occasionally I would give the levothyroxine. And the patients on the T4, the levothyroxine group, had a higher reverse T3, blocks the action of T3. That may be detrimental. They didn't really talk about that, but they did point it out in their table. So most importantly, the patients were asked, and they were blinded, they didn't know which one they got. They were asked which ones they liked better. 49% of them preferred the Armour thyroid, 19 preferred the levothyroxine, 33 didn't notice the difference. So there must be something in that they liked better than the standard one, the levothyroxine one. So there were some subtle improvements they were having with the Armour thyroid that wasn't recorded on the questionnaires that they liked it better. The subgroup that preferred the Armour thyroid lost even more weight. They lost 4 pounds of the Armour thyroid compared to the levothyroxine. They had better well-being, and their thyroid symptoms were simply better with better cognitive function on the Armour thyroid compared to the levothyroxine, the subgroup here. And this suggests, that is what I've always argued, that there's a subgroup of patients that need the Armour thyroid as opposed to the levothyroxine. These patients may be more poor converters from T4 to T3. And there were no side effects in the Armour thyroid group. Specifically, there was no increase in heart rate or pulse. The authors concluded that the improvement in Armour thyroid may not be detected by the relative insensitivity methods used in the study. And they used once a day desiccated thyroid. I recommend, as I said, twice a day. It led to modest weight loss and possible improvements without appreciable adverse effects. So my thoughts on this paper, I found it was a very well-designed paper. It was published in a very good journal, had a reasonable number of patients, well-written. And they gave the Armour thyroid as a single dose once a day without levothyroxine. And as I said, since Armour thyroid has T3, the short half-life, I think it would be better to give the Armour thyroid twice a day. They might have done better on those if they were on twice a day Armour thyroid compared to once a day. They might do better on a different type of desiccated thyroid. But clearly, the study refutes the claim that Armour thyroid is worse than levothyroxine that many endocrinologists are still saying. So, I mean, if somebody tries to get on desiccated thyroid, their doctor says, I won't do it because it's worse. And you can show them this paper. I think it was clear. And I think the study also pointed out the importance of trying to detect a subset of patients to put on desiccated thyroid. Not everybody needs to be on it, but there are certain people that do. It's important to try to figure out who's the ones that should be on it. The paper found that those who preferred the desiccated thyroid were more likely to have autoimmune thyroid disease, Hashimoto's, and had a slightly higher reverse T3, although they weren't significant. So those might be clues about somebody with Hashimoto, somebody with high reverse T3 might do better on desiccated thyroid. And then also, the study looked at all patients on hypothyroidism on levothyroxine patient replacement. Most of them are doing well. So if somebody's doing pretty well, they're probably not going to get better on the desiccated thyroid. But if somebody's doing poorly on it, they would have done better once they got switched over. So a lot of patients come to see me, they're not doing that well on levothyroxine, and they determine they probably should benefit from desiccated thyroid. So if your doctor doesn't want to prescribe desiccated thyroid, unfortunately there's still a lot of doctors out there that don't, please either show them this article or have them come see me. In general, for T4, T3, or desiccated thyroid, I have the patients take the thyroid medicine first thing in the morning on an empty stomach. If they're on a twice-a-day regimen, which I think most of my patients are, they take the second dose in mid-afternoon. And avoid taking, within an hour, I would say, with iron especially, interferes with absorption, calcium, vitamins that have iron or calcium. These proton pump inhibitors like omeprazole are very common. They interfere with the absorption. Carafate, Fosamax, which is oral bisphosphonate, orlistat or cholestyramine are all drugs that are pretty commonly used that interfere with the absorption. We'll talk about tyrosine in a second. I think tyrosine, you don't have to worry so much about this, but in general, for the patients on either the desiccated thyroid or T4 or T4, T3, you want to avoid these things. I think there's a minor effect of soy. I don't think it's that much, but you're probably better not to take it with soy. I usually have people take it an hour or 45 minutes before they eat on an empty stomach, both in the morning and in the afternoon. I don't, some people advocate for a 4-hour time. I don't think you need that. I think it's already absorbed within about 45 minutes. Yes.
Out of curiosity, what's the difference with tyrosine? Why doesn't it have?
Tyrosine does it's a gel. I have a slide on that. The tyrosine, because it's pure, it seems to, they've done studies on it, seems to not be affected by other drugs nearly as much. Good question. Some people go on T3 alone. The brand name of T3 is Cytomel, the generic is called liothyronine. There was a study done by Dr. Celiac with one of my colleagues, Monica Skaroulas, who was with me at the NIH, that treated patients with T3 alone, and they had lower weight and better profiles than those on T4 alone. I'll tell you why I don't recommend this. I think this is a fairly small population, but it's an interesting study that they did well also. I would rather give them a combination of T4, T3. I didn't look at combinations, just look at one or the other. It's interesting, a lot of alternative doctors are giving T3 only to their patients. Especially there's a group in Torrance that near where I work at that does this only. Pretty much anybody that walks the door gets the T3 treatment. And I recommend against this for several reasons. First of all, several studies have shown that T4 gets into the brain much better than T3 does. So both in animals and humans, what they try to do, the T4 doesn't pass the T3 doesn't go in the brain that well. The T4 gets into the brain, and then in the brain can get converted to T3. So I do think it's helpful to give T4 and T3. Otherwise, the level in the brain might be quite low. I had these patients that got sent by this other clinic on this T3, and I switched them over to T4, T3. They all do much better. T4 has a long half-life and acts as a reservoir, while T3 has a short half-life, and should be given several times a day or compounded to be a slow release, which can be expensive, and also sometimes it's not that good at compounding. So you can use the T4, the long half-life, sort of the baseline. T3 gives a little more energy, a little more boost, and I think that's better than the T3 alone. And if somebody truly has hypothyroidism and they are on T3 alone, their T4 should be 0. It goes from T4 to T3. It doesn't go backwards from T3 to T4. So if somebody has truly hypothyroidism and you give them T3, their T4 should be 0. I don't think that's good. I don't think it's good to have a hormone that your body makes that should be sort of normal and be suppressed like that. If people are misdiagnosed, they didn't have hypothyroidism at all, their T4 could be sort of low normal on it because their own thyroid's working. So I like, again, this reservoir effect of the T4 along with the short-acting boost effect of the T3. Okay, so tyrosine. Tyrosine is a gel capsule with almost no binders or fillers. It seems to interfere less with other medicines. At least they've looked at it more carefully. They have some studies with different types of antacids. For example, that can interfere with the absorption. You need an acidic, in general for thyroid medicine, you need an acidic stomach. Somebody's on antacids, they don't absorb it as well. The tyrosine seems to be okay with that. The downsides of the tyrosine is it's expensive and often not covered by your insurance. You have to appeal, you have to say the person's failed T4 before they get it covered, or you pay out of pocket. It could be at least $60 or $100 a month. It seems quite expensive. Just, I think about a week ago, a fixed dose of liquid came out. So this means that you can get a 100 microgram dose in a little liquid canister little thing, and you pop that in and take that every day. I think it would be much better to give you a big bottle, and then you can sort of titrate the dose yourself. You can do 111 or 105 based on some kind of syringe, but they didn't want to do that. They just gave a fixed dose liquid. I'm not really sure that much advantage of this. Maybe have a little less things than the gel, but I think people sort of like taking a jelly, pop the whole thing in the mouth and swallow it. The liquid, I think the concern is going to stand up on the sides of the tubes and stuff like that. So I'm not sure this is going to be that successful for the company, but we'll see. Okay, now let's talk about reverse T3. This is an interesting area that I sort of a little bit changed my thoughts on as I read more about it and looked at my own patients. So you get circulating T3. Again, T3 is the active hormone by this 5' deiodinase right here that goes to T3. There's it can do it at this outer ring. It takes off the iodine from here, the outer ring, or I could take it off from the inner ring to give it here. So you can either lose these two, there's 2 iodines here, there's 2 iodines here. It's called T4 because it has 4 iodines. You can either lose the one from here or lose the one from here. If you lose from the inner ring, you get reverse T3 down over here. And reverse T3 blocks T3 at the receptor. So it's bad for you to have a high reverse T3. I don't know. The question is how high is bad, but it seems to be detrimental. And this occurs by the T4 to T3, the one you want, goes by deionases 1 and 2. Again, it's at the, it removes it from the outer ring. The deionase 3, mostly with a little bit of deionase 2, makes the reverse T3, as shown over there. There's also T2 deionase in the thyroid that gets regulated a little differently from the deionase 1, but that also helps convert T4 to T3 in the pituitary. Now, reverse T3 is a biologically inactive form of T3 and may block T3 from binding to the thyroid hormone receptor. And many years ago, endocrinologists realized that in severe illness, the T-type 3 deionase increases, and you get a higher reverse T3, and the T3 itself is often low. And endocrinologists termed this sick-you thyroid syndrome, and noticed that it was common in many types of chronic diseases, chronic illnesses, especially hospitalized patients in the intensive care unit. It was usually recommended these patients not be treated with thyroid hormone. It was like adaptive, that they shouldn't be making T3 when they're sick, and that the elevated reverse T3 and the low T3 resolves when the patients get better. So this is what sort of most endocrinologists, including me, believed until a couple of years ago. So you have these alternative doctors, including the doctor down in Torrance at his clinic. They're now called functional medicine doctors, and they make quite an issue about this reverse T3. And they argue, I think somewhat appropriately, that the high reverse T3 is bad. It can block T3 from binding to the thyroid hormone receptor. They also said, and again, I'll talk about this in a second, they said that high reverse T3 can go up in various conditions, including systemic illness, stress, inflammation, chronic pain, dieting, weight gain, and depression. And they quote articles showing that these are correlated with reverse T3, but they don't necessarily show the role that reverse T3 causes these diseases. So people that are dieting or have inflammation or have chronic pain could have a higher reverse T3, but lowering it doesn't necessarily reverse those diseases. These functional medicine doctors often rely heavily on the reverse T3. They take something that's completely normal test, and maybe the reverse T3 is a little bit above some arbitrary cutoff they come up with, and they give them T3-only preparations to try to lower it. There's been no publications, either from this group, Holtorf's group, or from others, that shows that this actually works. It shows nothing's done that shows these patients do better when the reverse T3 is lower. So it's an idea that I think is interesting, but I think it sort of shows, and I'll see how I use it, but I think it needs more study. And they use a ratio, sometimes the high reverse T3 to T3 ratio, as an indication to treat these patients. And this is not my slide. This is somebody else. I'm not sure I completely agree with everything on the slide, but you have T4 going to either reverse T3 or T3. It goes into the cell. The T3 binds. Reverse T3 blocks it. So things that contribute to higher thyroid hormone production, including iron, which I certainly agree with, iodine, tyrosine, zinc, selenium, vitamins, can help. Factors that inhibit the production of thyroid hormones, stress, infection, trauma, radiation, medicines, fluoride, toxins, autoimmune diseases. Many of these are interesting ideas that haven't really been shown. Things that increase the T4 to reverse T3 include stress, trauma, low-calorie diet, inflammation, toxins, infections, liver kidney disease, certain medications. And factors that improve the conversion would be selenium, zinc. We'll talk about selenium in a little bit. Factors that improve the sensitivity of thyroid hormones include vitamin A, exercise, zinc, probably selenium also, and probably iron also. So what I decided to do is I measured reverse T3 in 98 consecutive patients who came to see me with potential thyroid problems. I did not get IRB approval for this. This was sort of a quality study here to see what I should be doing with these patients. All these had signs and symptoms of hypothyroidism. They came to see me because of hypothyroidism, and they were on different types of thyroid medicine. So that sort of gave me a little bit of advantage to look at what the reverse T3 was in these different preparations. And I used the upper limit of normal for reverse T3 at either Quest or LabCorp, where I sent the samples. It was about 24, so I used sort of 24 as a cutoff. I didn't look at any type of ratios or anything other than that. So this is my data here, and the numbers of the patients are at the bottom there. So there was 14 patients on desiccated thyroid, 3 patients on desiccated thyroid plus T3, 7 patients on desiccated thyroid plus T4, 28 patients on T4 alone, 35 patients on nothing. T3 alone had 3 patients, and T4, T3 had 8 patients. So you can see the ones that are above this box is like the 95% confidence interval. You can see that in desiccated thyroid, 14% were above this cutoff of 24. In desiccated plus T3, none of them were above the cutoff. In the desiccated T4, a high percentage of 57% were above this cutoff of 24. And that made me, again, question my idea about putting people on desiccated thyroid on T4 alone, as a lot of these patients had a high reverse T3. Patients on T4 alone, also a lot of them had a high reverse T3, 29%. So it seems like the T4 plus the desiccated T4 alone gives us high reverse T3. On nothing, almost none of them, only like 9% of them, and some of them that I repeated again the second time, it wasn't elevated. So a pretty low percentage of people on nothing had this high reverse T3. So I think this is useful for the people on the treatment to then fine-tune the treatment, not necessarily to put somebody on it. As you might expect, the people on T3 alone had a low reverse T3, which is good, but it wasn't always the whole story. And people on T4, T3 combinations, also none of them, or just one of them, I think, had a high reverse T3. So 18 of the 98 patients had a reverse T3 above the normal range. Very few of the patients on no thyroid medicine had a higher reverse T3. Several of those on a T4, T3 combination, and desiccated thyroid T4 combinations had a high reverse T3. None of those on T3 alone or desiccated thyroid T3 combinations had a high reverse T3. I didn't look at whether the reverse T3 was correlated with the hypothyroid symptoms. And I have several patients with a high reverse T3 are doing pretty well, and several patients with a low reverse T3 are not doing well. So again, I'm not sure that this is the be-all and end-all, but I would say if you have a choice and you're treating somebody for thyroid medicine and they have a high reverse T3, it's worth trying to lower it by either taking them off the T4 or trying to give them some T3 to try to lower that reverse T3 to see if that helps them. So measuring the reverse T3 may be helpful in some patients, especially those that are already on thyroid treatment that contain T4. Most patients do not have an elevated reverse T3 treatment. The patients that do have an elevated reverse T3 treatment on either T4 alone or T4 plus desiccated thyroid may benefit from decreasing the amount of T4 and increasing the amount of T3 of the desiccated thyroid. Doing more T3 kicks out the T4 and should lower the reverse T3, kicks out the reverse T3 and should lower the reverse T3 and may be helpful. So because of this, I'm not giving T4 plus desiccated thyroid at the initial visit. I put them on just desiccated thyroid, and then if they have a low free T3 and a pretty normal or non-elevated reverse T3, let's say less than 20, then I might start them on T4. But initially, I would give everybody the desiccated thyroid. I think this is an interesting area. There's a clear division between endocrinologists who don't measure this at all. I'm probably going to be the first one to publish this. And the functional doctors who put this on, measure this on everybody, treat almost everybody. Hope to get IRB approval and write up a paper on this. And I think, again, this test can be helpful in certain patients, but you need to use discretion, especially who starts thyroid medicine. Thyroid medicine is a lifelong condition. Somebody has a little slightly elevated reverse T3 or a slightly elevated reverse T3 ratio. I'm not sure it's worth it. I'm probably pretty sure it's not worth it to give them T3 or T4 the rest of their life to try to correct this off and certainly repeat it and see if it's still elevated. But the people that are on it, on T4, I think that's the people that you should measure this and correct it. Okay, I'm going to close the morning in the first session here with what's called the thyroid diet. What is the thyroid diet? And I would say it's a clean diet. I recommend this in all my patients, whether they have thyroid disease or not. Lots of fruits and vegetables, limit processed foods, limit simple carbohydrates, pasta, cereal, grain, tortillas, rice, potatoes, things like that. And otherwise, I'd say there's very little data, and I try to go by what's published on data on specific diets for patients. There's a lot of stuff on the internet that's not peer reviewed. Somebody can put anything they want on the internet, trying to espouse a certain diet or a certain food to avoid. But when you look at articles in the literature, there's really very little of this. Functional doctors promote diets to address a condition that's termed sort of a new disease called leaky gut. And this is not a condition that most doctors, regular doctors, recognize at all. But these functional doctors are very interested in this. There's also this idea about Hashimoto's disease of inflammation. No data on that. So a review article that really didn't even consider that as one of the possibilities. Hashimoto's is a genetic disease. People have the genes for the TPO antibody. It's not really an inflammatory disease. This idea about gluten-free also, I think there's no data on this. I'll explain why in a second. There was a nice review article by Dr. Young on Medscape, and there's a citation called a Thyroiditis or such a thing. I thought that gave a sort of balanced review of the issue. So there's a review article on Hashimoto's and hypothyroidism published in Hormone and Metabolic Research about a year ago. Very in-depth article, cited a couple hundred articles, looked at all the different causes of Hashimoto's. There was no discussion of inflammation. No this was, we picked up the literature, it was like a meta-analysis. There was no articles in the literature on inflammation and no articles in the literature on gluten. They talked a little bit about a hygienic environment, modest epidemiological evidence on Hashimoto's that a hygienic environment makes it worse. Selenium deficiency, moderate evidence. Vitamin D deficiency, weak evidence, maybe the result of hypothyroidism, not the cause. Drugs, cytokine, especially these tyrosine kinase inhibitors that are used a lot for cancers. These things definitely seem to make Hashimoto's work, but again, these things aren't that used. Interesting enough, smoking and alcohol have a protective effect. So people who smoke have lower rates of Hashimoto. People who use alcohol have lower rates of Hashimoto's. So I don't recommend people going out and smoking and drinking. That's what data shows. So this article again is very good at listing different causes, including those, but nothing again about inflammation and gluten. Infections, there's some ideas about infections, herpes, HV6, Yersinia viruses, but there hasn't been really any studies like isolating the virus and confirming that this is causal. Environmental toxins, very limited evidence about that. And radiation, there seems to be a little bit of data, especially places like Chernobyl. There was an increase in Hashimoto's following nuclear radiation fallout, but I think the average person in the United States, hopefully, we're not exposed to it. When they had the nuclear reactor in Japan that leaked, there were people in California who were worried about it, but people in California were so far. People I got from all over the country, basically, but we're so far away from that, it really didn't affect us. So I think this idea about gluten or inflammation causing Hashimoto's, there really isn't any data to support that. People ask about iodine deficiency. I would say in general, iodine deficiency is relatively rare in the United States. Salt is fortified with iodine. Most processed foods have a lot of salt, unfortunately. There are people that say, I don't eat any processed foods, and I don't eat any seafood, and I live inland, and I live in the Great Lakes area. It used to be the iodine deficient area. But I don't think there's that many people that have that. As I mentioned, T4, levothyroxine has 4 molecules of iodine, T3 has 3 molecules. If you're on thyroid medicine, you're getting enough iodine, certainly. You can take a vitamin that has iodine if you want. There's these iodine for thyroid health supplements. They have several hundred-folds the amount of iodine in just a single dose. These I would really try to avoid. You have other products for thyroid support. These include spirulina, which is a superfood from algae, kelp. These have a fair amount of iodine in them, probably not as bad as the other ones that have super high levels, but most people, I don't think, need it. In some individuals, there's certainly a lot of literature on this. Excessive iodine exposure may trigger both hypothyroidism and hypo. So you have somebody that's borderline hypo, you give them iodine, it could make it worse. You have someone with borderline hyper, you give them iodine, it could make both of them worse. The chronic iodine may induce autoimmune thyroiditis, as when the iodine the thyroid globulin gets heavily iodated, it's more immunogenic, can lead to Hashimoto's. So I would be cautious about alternative doctors that try to treat your hypothyroidism with iodine. Now, on the other hand, selenium, I think, is a pretty interesting supplement. It does increase T4 to T3 conversion. It reduces TPO antibody levels, so it's a pretty good supplement for that. Patients with untreated growth hormone deficiency have decreased T4 to T3 conversion, so they're likely to benefit from selenium, but again, I'm a big fan of growth hormone, and people that need it, just give them growth hormone, you correct the problem. There is some literature that selenium increases the rate of diabetes. So because of that, I'm a little cautious of people that have prediabetes. I don't want to tip them over to diabetes, someone with a strong family history of diabetes. You know, if I put them on this, I would watch their hemoglobin A1C, for example. If somebody already is on thyroid medicine, especially on T4, T3, I mentioned what you need for this because you're already getting the T4 and T3 that the selenium will help with the conversion of. The term goitrogens, this refers to a substance that can produce a goiter, and goiter is an enlargement of the thyroid gland. The most common examples of dietary goitrogens are cruciferous vegetables and soy products. These are in the Brassica genus and include broccoli, cabbage, Brussels sprouts, kale, turnips, cauliflower, collard greens, and bok choy. And I think it's sort of good, our society, everybody's eating kale now, especially in California. I don't know where you guys are from, but kale's very big now. I think kale's great. And I think you want to avoid probably especially when somebody is untreated or sort of borderline, you might want to avoid a lot of these. But I think if you do a little bit, just have some kale in your salad every couple of days, you're probably okay. I just probably wouldn't eat a huge amount. If you're borderline, if you're perfectly normal, it's probably okay. If you're on treatment, it's okay. If you're sort of borderline hypothyroid and you're not on treatment yet, you might want to watch it a little bit. Okay, now we'll talk about this controversy about celiac disease and Hashimoto's. I think there's a lot of misinformation on this. Both celiac disease, and one which somebody needs to be on a strict gluten-free diet, and Hashimoto's hypothyroidism are autoimmune disease. If you have Hashimoto's hypothyroidism, you're more prone to getting celiac disease. So, for example, I just made these numbers up. About 1 out of 10,000 people have celiac disease in the United States. But if you have Hashimoto's, it goes up to 1 out of 1,000. So it's tenfold more common in Hashimoto's than non-Hashimoto's, but it's still only 1 out of 1,000. So most people don't have Hashimoto's, don't have celiac disease, and they don't need to be on a gluten-free diet. I do find that eliminating wheat, reducing carbohydrates, you may feel better, especially the people who have a lot of symptoms of gluten intolerance, the bloating, gas, GI symptoms. You may feel a little bit better, but I don't think you have to be strict about it. I don't think it's the be-all, end-all. I have patients that don't have any GI symptoms, are super strict about it. It doesn't really help your thyroid at all, unless you have GI issues. So some of these doctors I've seen, or functional doctors, say the gluten protein resembles the TPO antibody, so by eating gluten, you're causing your TPO to be worse. I looked this up on Wikipedia and got some pictures of this. Gluten is a protein. It's basically a protein with carbohydrates on it. It has gliadin, which is water-soluble, and glutamine, which is water-insoluble. It looks something like this. TPO is an enzyme, so it looks quite different. It has a binding site pocket in it, and it's involved in the incorporation of iodine into thyroid globulin for the production of thyroid hormone. So this idea that you don't want to take gluten because it makes your Hashimoto's worse, I think it's not correct. So what is my thyroid diet in general? Healthy diet, lots of vegetables, exercise, as the speaker before me talked all about. I think I find that more as I get older, I need exercise more. As I push exercise to all my patients, whatever they have, they do much better when they exercise if they can. Studies have shown that people that are able to exercise live much longer than people that can't. So I really like people to exercise as much as they can do. And then I think most of it is getting your thyroid treated properly. I think you can be on an anti-inflammatory diet or gluten-free diet all you want. And basically, if you have hypothyroidism, you need thyroid medicine and you need the right combination of T4 and T3 to get properly treated. So you can go look at my website. This will be probably posted in a couple of days. This is what they're asked about. You can email us for questions or make an appointment. Special thanks to the Magic Foundation for inviting me and all the great work they do. The Magic Foundation is one of the best charities in America, as certified by the Independent Charities of America, and it's one of the top-rated great nonprofits. We've got the certification here, so keep on coming to Magic's events. We have a couple minutes for questions. We'll have the whole session at the end. We'll maybe have a couple minutes for questions. Start with you, then you.
When you first start patients on NDT or not, what should you do twice a day doses?
Yeah.
How do you start in terms of the amount that you start on and how quickly you go up and when you
Right. So some people are on T4 and they try to convert them approximately somewhere about 60 to 100 micrograms. We were talking about 1 grain of desiccated thyroid. Some people are on that and they have symptoms of hypo, and I might give them more. Some people are on that and they have symptoms of hyper, so I give them a little less. Starting off, I usually would probably start people. It depends if there's sort of just a slightly elevated TSH. I might start them like a quarter grain twice a day. If they're pretty severe, I might give them half a grain twice a day. After 1 grain a day is about average dose. And people that are overweight probably need more than normal.
So 1 grain in the morning?
No, half grain twice a day. And then I would check them in about 6 weeks to 2 months and adjust the weight.
So have you heard of people that are only on like Levothyroxine, having palpitations, tachycardia, even with the normal?
That's a good question also. I think people, first of all, there's 2 different types of thyroid hormone receptors, the alpha and beta receptor. They can have different receptor expression at different, their heart versus their brain. So they could, they could be feel like hypothyroid in the brain or hyper in the heart. And some of those patients, I drop a dose so they do better. Even though the TSH is a normal, maybe TSH is 1, maybe they live at a TSH of 3, so they drop the dose a little bit, so do better. And patients who very recently did that, and everybody knows what TSH, but pre-T4 was high, even though the TSH was normal, so these doses do much better. I'm not sure some of those would benefit from, desiccated thyroid because it has a T3, which might make the palpitations worse. And then there's other reasons for palpitations. So volume depletion, like anemia, iron deficiency, that probably gives a lot of people palpitations. So I try to inflate their iron, if they're dehydrated, and take salt, liquids maybe, occasionally give glucocortisone. Magnesium I find very helpful for palpitations. So we try to, address beta blockers, makes you tired a little bit, beta blockers help with palpitations. So I try to address both optimizing the thyroid and optimizing the palpitations.
You mentioned Celiac for T4 T3 conversion. Someone in my reverse T3 was had, someone looked at my diet and they said, well, each meal was good, that I probably wasn't getting everything I needed. Just for reverse T3. Does that sound reasonable?
Well, I think it sounds reasonable because it helps the T4 T3 conversion. So you can get a little more T3, which is going to sort of knock out or kick down the reverse T3.
Okay, so 2 Brazil nuts a day wouldn't be bad.
What?
2 Brazil nuts a day wouldn't be bad.
Probably okay. So you can either get Celiac trachozones or Brazil nuts. Yeah.
Is there a valid reason why a doctor would refuse to give T3 or touch a reverse T3? Is it a different school of thought?
Yeah, I think it's a different school of thought. So the Endocrinologist Society guidelines and the American Thyroid Association guidelines probably better don't recommend this. Don't recommend reverse T3 and recommend only giving T4. I think more doctors are giving T4 T3 combinations, but still very few doctors give desiccated thyroid. I think, again, it's sort of like it went out of favor when they started with T4. There was editorial, you shouldn't be giving this anymore. It's a little bit of a divide between sort of more alternative or more modern, more open doctors to more traditional doctors. But, I think there's doctors that certainly do it, and I certainly do it, so you have to find the doctor you like. I think also doctors don't know how to use it.
Yeah.
So they don't want to give something, they worry about the side effects, and, they all give it once a day. Which again, I think is worse. So I think it's better to go to somebody that knows what they're doing.
And so we open that conversation and we're happy with our technology. Is there a study? Is there?
I think that study with JCM that compared the two is the best study. I mean, it was clear study, good institution, published in a high quality journal, lots of patients. I would show that article.
Gave a throwaway line that I think it was you put chronic pain and low T3, T4 in the same sentence. You correlate.
Not necessarily. So I
think that was from another article, like preface to that. It wasn't my article, it wasn't my slide. I think chronic diseases, as we know from people that are really sick, does lead to high reverse T3. Whether somebody with chronic pain is enough, that's all you say. There's probably odds of somebody with chronic pain to have a higher reverse T3 and lower T3 than somebody without it, but no studies on that at all. So, it might be a good person, especially the reverse T3. So let's do one more question, and then we have time at the end for more questions. Right. So there's a lot of choices. It's just sort of like, what's the best blood pressure medicine? I think it varies. So in general, I usually use more desiccated thyroid because I think it has the T4, T3 in it in pretty good ratio. It has the other things that are beneficial in the thyroid that are missing in synthetics. So I usually start with that. The patients that are on T4 and not doing well. Some patients that, maybe just need a little tweak, maybe I'll add some T3 to them. And they like the T4. Some people do religious reasons or animal issues with animal, don't eat animal products or something like that. May not want desiccated thyroid. So I always try to individualize what the patient wants. But I would say in general, I probably would use desiccated. Okay, let's go on to the next slide. Next set of talks.